So we'll start with our first presentation, going to be from Dr. Christian Spalding from France. He's a professor of cardiology in Paris University, and he will talk to us about cardiogenic shock. How far should we go? Going to be online and virtual with us.
Hello, my name is Christian Spalding. I'm an interventional cardiologist from the European Hospital Georges Pompidou in Paris, France, and it's a real pleasure to be invited to this fantastic meeting to talk about cardiogenic shock. These are my conflicts of interest. So today we're going to see the interventional cardiologist perspective. Should we do complete revascularization or only culprit lesion? Should we do simple or complex PCI? And mostly we'll talk about the role of cardiac assist. So the first question, should we do culprit only or complete revascularization? This has been solved by the culprit shock trial, which clearly demonstrated that it was better to do the culprit lesion only compared to a multi-vessel PCI with a reduction of mortality in the culprit lesion only group. The other tips that you can give during treatment of a patient with cardiogenic shock is that you should work as a team, have an anesthesiologist in the team in your cath lab, call the cardiac shock team if you have one. And if you do PCI, try to keep it as simple as possible. The aim is to open the artery and keep the procedure short and the amount of contrast medium to a minimum, and in particular, avoid complex bifurcations and trying to be absolutely perfect. So the other question is, should we use a cardiac assist or not? Let's first talk about intra-aortic balloon pump. And this also has been solved by the IBP2 Shock 2 trial, which clearly demonstrated that there was no difference between treating the patients medically and inserting an intra-aortic balloon pump in a patient with cardiogenic shock. And this may be a little bit of a surprise to many of you, but currently there are no indication for a balloon pump in cardiogenic shock, except for patients who have mechanical complications before they go to the operating room. Second, cardiocirculatory support, the Impella device. The advantage of the Impella device is that's a relatively easy, simple system to use. It's basically plug and play. It takes about 10 or 15 minutes to insert the device. That provides up to 3.5 liters per minute of cardiac flow. It is relatively easy to place and relatively easy to control. There have been many registries that have suggested an improvement of mortality with the use of the Impella in cardiogenic shock. This is a study that we did several years ago in France, showing a pretty good outcome in patients with cardiogenic shock. However, there are other registries that have been published. This is a propensity score analysis performed in the US, comparing the intra-aortic balloon pump when it was used in the past to the use of the Impella. And as you can see, there is more bleeding, a higher rate of mortality in the group that receives the Impella. There has also been other studies, such as randomized studies done, however, in small number of patients that have shown no difference between patients receiving the balloon pump and the Impella. There is a large study that probably will answer the question of the use of the Impella in cardiogenic shock that is currently ongoing, the Dan shock, that has had many difficulties, including patients, but that it is doing pretty well, and hopefully we will get the answers from this study on the use of the Impella. One question, and this is basically not only for the Impella, but also for the Ecmo that we'll see after, should we implant it before or after PCI? This is a very difficult question to answer. I think that the decision has to be taken case by case. However, if you look at the data, studies that have compared the implantation of the Impella device after the PCI compared to before the PCI have clearly shown that it is better to implant it before PCI rather than late. Finally, VA Ecmo. Once again, there are many studies, many registries that have shown that there is seems to be an improved prognosis with VA Ecmo in cardiogenic shock. This is a study that we did in France several years ago, showing a relatively favorable reduction of mortality with VA Ecmo. However, there are no randomized trial. There is a randomized trial that is currently ongoing in France right now, which is going to compare medical therapy to the use of Ecmo for cardiogenic shock that is due to IMI. And hopefully we'll have the answer to that question also, but probably in at least 2 or 3 years. Once again, with all the devices, whether it's Ecmo and Impella, don't forget that there are complications. One of the major complications of these devices are limb ischemia and vascular complications that can occur up to 7 or 10% of cases, and it can have dramatic consequences in our patients. A little word about pre-hospital ECMO. In Paris, we are using pre-hospital ECMO for refractory cardiac arrest. It is implanted by the emergency medical system, the SAMU, anywhere in Paris. As you can see, it was implanted in the Louvre Museum, in the supermarket streets, in the crowded Parisian subway, and we seem to have good results with this system. This is maybe the most important slide of all the presentation. I've shown you registry data. I've shown you the fact that we don't have randomized data for the use of cardiac assist devices. However, there is one study that has shown an effective therapeutic method in cardiogenic shock. It's the shock trial that has clearly demonstrated that reverse vascularization improves mortality in the acute phase of AMI with cardiogenic shock. It was also demonstrated by several registries, such as the one performed in our center. So the message is very clear. The only randomized study that has shown an effectiveness is cardiogenic shock is a shock trial, and therefore it's angioplasty. And once you have opened up the artery, you have done the job. The rest has to be demonstrated in the future, and we don't have very much data to support the use of the cardiac assist devices. So to summarize, what should we do in centers without cardiac assist? Once again, open the culprit artery, work in a network with tertiary center, and most important, and this is also a very important message, early transfer of patients with cardiogenic shock, which is easy, but mostly the patients who are at high risk of developing cardiogenic shock, is better transferring the patients before they develop cardiogenic shock. So should centers without cardiac assist invest in Impella? The problem with Impella, it's a fantastic machine. However, it needs a learning curve and experience. This learning curve and experience can actually be obtained if you use Impella in high risk of PCI, but I wouldn't advise investing in Impella only for cardiogenic shock. In tertiary centers with cardiac assist, the Impella is easy. You have the choice between an Impella and an Ecmo. The Impella is easy and fast to use, gives up to 3.5 liters per minute. However, it does not provide oxygenation and right ventricle support. Therefore, the best indications are patients with no right ventricle dysfunction and transient left ventricle dysfunction, for example, patients who have acute MI. Ecmo provides oxygenation, left and right ventricle support. However, it's more difficult to implant. It has a high rate of vascular complications. It doesn't allow a left ventricle unloading, and therefore the best indications are patients with left and right ventricle dysfunction, need for oxygenation, refractory cardiac arrest, and in some cases you can also use both Impella and Ecmo, especially if you are unloading the ventricle with Ecmo. So in conclusion, culprit only PCI in cardiogenic shock. Work as a team, keep PCI fast and simple. Data on cardiac assist in cardiogenic shock is limited, and therefore that's why opening the artery is the most important thing you can do in these patients. Centers without cardiac assist should transfer patients early with cardiogenic shock, or especially patients who are at risk of developing cardiogenic shock. Centers with cardiac assist should use cardiac assist in selected patients using predefined protocols, inclusion in trials and registries, and early implantation seems better. And most of all, this is a teamwork which will imply interventional cardiologists, anesthesiologists, and cardiac surgeons. Thank you for your attention.
A great presentation and a very important topic, as people know that shock have been an important aspect in the cath lab, and it's not luxury anymore to have a circulatory support devices like Ambilla or Ecmo. It's become mandatory to have at least the algorithm how to deal with these cases. So I'll allow my dear panelists to have any question or comment to Professor.
Thank you very much, Professor Spalding, for the nice presentation. Can you comment in some cases where you have LV and RV where ECMO is not possible? There are some data or cases, sorry, that using right-sided impeller to unload the RV, so left and right-sided.
Yeah, that's right. There is the LV impeller is the one that is the most used, and there have been cases of RV impeller that has been used, and cases where actually patients have been implanted with an LV and an RV impeller. So that is true. It does exist. It's not current practice for the moment.
And in which condition you consider use the impeller, both ECMO and impeller together?
That's a very good question. Well, as you know, when you implant an Ecmo, actually there's a problem with the left ventricle, and you need to unload the left ventricle, because basically it fills out, it's working against resistance. And there are three methods that are currently being used. There's one which has been suggested by my colleagues in Paris from the Pitié-Salpêtrière, as to implant an intra-aortic balloon pump to be able to reduce the load. There has been the creation of a shunt between the left and the right atrium, also to be able to reduce to unload the left ventricle. And finally, the use of an impeller, which means you implant an impeller and actually it unloads the left ventricle. I think that each center should actually choose the method they use. We have used all three. Creation of a shunt, you need somebody who needs to do it, who knows how to do a transeptal and to create the shunt. The IBP is actually the easiest thing to do. The impeller is extremely effective, but that means that you're going to have two big catheters in each femoral artery, which can increase local complications. But my personal choice between the three, the most effective method is the impeller with the Ecmo.
Great. Maybe you'll go to Dr. Ali.
Thank you, Professor Spalding. Very nice lecture, very informative. I just have a question regarding the use of intra-aortic balloon pumps. As you mentioned, there was no data to suggest that it is effective in cardiogenic shock patients. And what our center, we have limited number of impellers, so we're very conservative with its use. And the data really shows that impeller is very effective in high-risk PCI. And I mean, there's definitely a role in cardiogenic shock, but since we have limited resources, we try to be conservative with it. So a lot of times when we're dealing with shock patients, we go with the balloon pump. It's widely available, it's cheaper, and that's what we go with. So my question is, are you inferring that we should not use balloon pumps anymore, like we should not invest in them as much? invest more in impellers or Ecmos as opposed to balloon pumps?
Well, that's an excellent question. Actually, we have the same problem in France. In fact, it's even worse because the impeller is not reimbursed. And in France, it costs between 10 and 14,000 euros. So it's a real problem. So it's only used in very selected centers. And Ecmo basically is a little bit cheaper than impeller. The balloon pump, I mean, you have to be very clear. I know that there's a lot of use of the balloon pump in cardiogenic shock because people feel that that's the only thing that they can do. But if you look at the study, at the IBD shock trial, I mean, it's clear. There's actually no difference between medical therapy and the balloon pump. So if you put a balloon pump in the patient, you feel better, but the patient is not going to get better at all. Everybody's going to say, oh, wow, this is great. We've done something that's good for the patient, but the study is very clear. You have not done one single thing for the patient. So I personally, and our center does not implant balloon pumps anymore for cardiogenic shock. If you're working in a center that has limited resources, what I would do is that I would work with a tertiary center and transfer early. And I think that's one of my messages, transfer early the patient. When the patient has a cardiogenic shock, it's easy to recognize it and to transfer the patient. The most difficult part is actually selecting the patients who have big anterior MIs, who have tachycardia, who have blood pressure that is just at the limit. And these patients and a low ejection fraction, prior PCI, prior CABG, these patients have a high risk of developing high lactates, and these patients have a risk of developing cardiogenic shock. And I believe that these are the patients that you should transfer to the centers, even if they are only there for 2 or 3 days for observation and then come back, because they may need an Ecmo or even more, which means heavier cardiac assist devices, and then we even go up to transplantation. So transfer early. And to answer your question, no, I don't use balloon pumps anymore.
Thank you. Thank you very much.
Dr. Abdullah?
Dr. Spalding, nice to see you. We'll love to see you physically here. Unfortunately,
So
you're not
would
with
I.
us. Right. I mean, I just want to say, because we are complications and GIS, we call it. So something we induce as a cardiogenic shock during the cath while we're working and this happened now. How can I predict this is going to happen? And the outcome, because somebody comes with cardiogenic shock, it's easy to speak to the family and say, look, the outcome is bad. But, to induce it myself in the cath lab, that one how can I recognize that one? And if it happens, how can I tackle it?
Yeah, that's a very good question, is how to predict the occurrence of cardiogenic shock. They have many publications that have been published that suggested scores, but basically it all comes up to the same thing. It's the large anterior MIs or MIs that occur in patients who have had previous MIs, or the other risk factors are patients who have had previous CABG, previous MI, patients who have tachycardia, and lactates is a good indicator. If you start having lactates that start rising, this is also a good indication. And poor left ventricle ejection fraction when you do an echo before you start opening up the artery. And I think it's important when you receive a patient who has an acute MI, we all have a tendency of jumping on either the femoral or the radial artery to open up the artery, and we're right, every minute counts, but I think it's important just to take 2 or 3 minutes before the case to have somebody do a rapid echo, to look at the electrocardiogram and to try to get together all the components that will eventually lead to a cardiogenic shock. And that is the most difficult. And that's also the difficult decisions when you have a borderline patient should I include the patient, should I implant the device, for example, the Impella now, before the PCI, or after? And it's difficult decisions that have to be taken patient from patient.
Great. Actually, that's the beauty of the recent classification of shock, like from stage A to D. So you can recognize that patient will go from A to B to C, and you can catch them up before reach at least stage C. Dr. Abdullah?
Thank you, Dr. Spalding, for an excellent presentation. I actually have a comment and a question. So our center actually implants a lot of Ecmos and Impellas for cardiogenic shock. And maybe I just quickly share what we've learned from our experience. And I think what we've learned that patients usually present with hemodynamic cardiogenic shock. And if you wait long enough, it will become a metabolic shock. And at that point, no matter what you do, you're not going to save that patient. So the bottom line is early institution of support if you're going to use it. Why? Because the support can help the hemodynamics, but it cannot help the multi-organ failure. So if the patient reaches multi-organ failure, it's too late. So that's one of the lessons we learned. The other thing is meticulous skills with large bore access, because you're not going to gain benefit if you can induce complications. 3, cardiogenic shock is not only a procedure you do with the cath lab. The patient will be followed in the CCU. So the CCU team has to have, even including the nurses, they have to have the skills to manage these patients and follow for complications. So my question for you is regarding the use of venting techniques in Ecmo patients. So early in our experience, we used a lot of Ecpella, but we are shying away from it because we noticed patients have significant thrombocytopenia when you use Ecmo and Impella. And one of the things I learned from our cardiovascular anesthesiologist, we switched from using heparin to using Angiomax because it helps reduce the heparin. I was wondering if you have some other techniques to reduce the issue of thrombocytopenia. To be honest, nowadays, mostly I use balloon pumps, less in cases with really severe LV dysfunction, especially the ones where the aortic valve is actually not opening because of the increased afterload induced by the Ecmo. Thank you.
Okay, so thanks a lot for these comments. I think we both agree on the fact that you should implant it early, whether it's the Impella or the Ecmo, because it's going to be too late. Also agree with the comment on the fact that it should be tertiary centers with not only the interventional cardiologist surgeon, but also the nurses that are used to using these machines so that there's no complications. The question of the femoral axis is absolutely vital, and it's a question that I have on a regular basis with my surgeons. Should these devices be implanted in the OR or in the cath lab? I believe that it's probably better to implant them in the cath lab because you've got fluoro to be able to check where you go. And when it's done in the cath lab, there's an interventional cardiologist and a surgeon that is doing the procedure. So totally agree on that, because that's where you can get the complications. Venting, well, it's Angiomax. We have never tried it, so that's good news, because we've had exactly the same problem with the Impella, with hemolysis also that occurs with Impella after a few days. So I agree with that. Angiomax, it's a good idea. I'm going to suggest it. And which system do we use right now? We've used all three, and we're exactly at the same point where you are, which is that we have come back to the balloon pump because it's easy and it's simple and it works in most cases. And if it doesn't work, well, we go up to another step. We implant the Impella. We have a tendency right now, if we know that the patient is going to be on a long-term Ecmo, not implanting the Impella, the femoral Impella, but asking the surgeon to implant the surgical Impella, the 5.0 through the axillary axis, because there's less local complications. But thanks a lot for all these great comments.
Great.
Very short question. What do you think about the role of super saturated oxygen therapy and hypothermia in prevention and the treatment of shock in anterior volume eye especially?
I didn't understand the question. I suppose it's the use of hypothermia in cardiogenic shock?
And super saturated oxygen therapy.
Well, Subacetylation therapy, I'm not really familiar with that, so I can't answer that question. Hypothermia, for the moment, it hasn't really been proven in large acute myocardial infarctions. In fact, hypothermia is even, I mean, we're coming back on the use of hypothermia in cardiac arrest. The more the time goes, the more the temperature is rising. It's just like global warming in the ICUs. The temperature for cardiac arrest has gone from 30 to 32, and it's now back almost to 36 right now.
Great. Thank you very much, Professor Spalding. It's a great presentation, and I think you handled the question and comments in an amazing way. We'll go to our next presentation by Dr. Mohammed Al-Shamri.
Okay, good afternoon, everybody. Thanks for attending. Special thanks to the GIS presidency and all the members for the kind invitation. The next slide. So, my name is Dr. Mohammed Al-Shamari. I work in the new Jahra Hospital. This is the latest mega hospital to be opened in Kuwait. It was opened last year, and the cath lab there is only 6 months old. I have no conflicts of interest. I'm going to share with you a single case of a young lady that I did in the new hospital. She's a 35 years old lady who had no past medical history. She's not on any regular medications. Her family history only remarkable for a father who had a coronary artery bypass grafting in his early 60s. She works as a teacher. She's not married, non-smoker. However, she had morbid obesity with a BMI of almost 35. This lady presented to our hospital with acute severe chest pain with a background history of 2 to 3 days of mild to moderate chest pains. In fact, she was discharged from the emergency room the day before admission with the normal ECG and normal cardiac enzymes. On examination, she was hemodynamically stable. She had no evidence of any fluid overload or cardiac murmurs. In the ER, her I-stat was high, I-stat troponin 8.4, and this is her first ECG. They got the cardiologist on call who saw the patient, interpreted this ECG as an acute anterior ST elevation MI with severe chest pain, excluded contraindications for thrombolysis, and she was lysed with metalase. This is her 60 minutes ECG post thrombolysis. She had no chest pain, more than 50% resolution of the ST elevation. However, 20 minutes later, she had another episode of severe chest pain with sweating, nausea, and re-elevation of the ST segment in the anterior leads. In the meantime, she had a transthoracic echo. Her LV systolic function was normal. However, she had severe hypokinesia of the apical segments. Because it's a new hospital, we are very selective in taking patients to the cath lab. This is a young lady with no past medical history. Given her ECG and echocardiography findings, it was interpreted that most likely she had a mid-LAD occlusion rather than a proximal LAD occlusion. So the first decision I had to make, and this is a question for everyone here, would you take this lady for a rescue PCI? Would you shift her for another hospital, given that you have a new hospital with no cardiothoracic support and no mechanical circulatory support? So do you want me to go ahead, or should I?
Just a quick answer from the
quick, yeah. Yes or no? So we were thinking of a spontaneous coronary artery dissection given the phenotype of the patient and her presentation.
And you give one time thrombolytics. I think it's you give a thrombolytic, so it's justifiable to go and have a look. So you should go for doing coronary angiogram, giving this the very short period of giving re-ST segment elevation MI.
Okay.
Yeah, I would agree. I'll take her to the lab. Just take shots, see what her coronaries look like. Doesn't mean that I will intervene, but at least I'll see what's happening with this lady. Quite often, spontaneous dissection, you would tend to leave it, not to intervene. Don't even touch it.
Excellent.
Okay, so seems to be all people here would like to take her to cath lab.
I just have one comment. I mean, obviously, probably there's a high index of suspicion this lady has SCAD. And, you know, you'll probably go through the case, but
Sure.
I think it's better that if you have a hospital with cardiothoracic surgery on board that is not far away, that is within 30 minutes, 1 hour, whatever, then I think it's probably safer to send her there, because sometimes with SCAD, if you can't revascularize it, you can't wire it, whatever, then she will need urgent cabbage, especially if she's unstable. So I would actually transfer her to a surgical capable hospital.
I think in practical, everybody will take her to cath lab.
Yes.
Because you present it in a GIS complication, everybody will think like we maybe transfer better. So let's see what.
Yeah,
what
so based that she's got ongoing severe chest pain with ST elevation, we decided to take her to the cath lab. So right radial artery, axis 6 French. This is her right system, GR4 diagnostic catheter, and the RCA looks, there is no significant lesions on the right side. I took a guide to the left system, XB 3.56 French. As you can see, this is the first picture. There is almost no left main with almost separate ostia of the LAD and the left circumflex. And you could see that the guide is deep and selective in the LAD. The left circumflex looks normal. So the next picture, the areocranial, and we interpreted that as a mid-LAD occlusive dissection. So you could see it there. I think this is the LAD just beyond the first diagonal. So now the guide is selective in the left circumflex. You could see the LAD and the diagonal, and still the left circumflex looks widely patent. So this is the next question. The patient still got ongoing severe chest pain and ST elevation. Would you attempt PCI to that mid-LAD or not?
On the SCAD algorithm, if you follow the algorithm, this lady is unstable. She needs to have revascularization. Obviously, it's very risky. The first thing, obviously, you should not go radial with SCAD patients. You should go femoral, because you can engage the vessel more gently. When you go aggressive with the engagement, you can, these patients, they have endothelial dysfunction. You can dissect the vessel very easily. So it's better to go actually femoral, believe it or not. You have more control of the catheter. You can engage more gently, and then you have to be very gentle with wiring and all of this. But by the algorithm, yes, you need to revascularize. This patient is unstable, and there's no flow.
Thank you. Dr. Abdullah.
Yeah, that's easy to say. How to get into the right lumen? That's the problem, isn't it? With the,
Yes.
with that's
who gonna change
many ways.
the guide here to GL35?
Who would stop at this point and go conservative? Nobody. Okay.
She still has chest pain?
Yeah, and ST elevation. Actually, we didn't have time to have this discussion in the cath lab, because immediately after that picture, the lady had more severe chest pain. She got agitated. She was moving all 4 limbs. She got severe bradycardia.
A simple thing. Who's going to change the guide here? Are you people happy with this, or do you want to change it to GL35? It will be less traumatic, and I think it's because you are deep in there, so maybe people have some.
Yeah, but yeah. Severe hypotension, more prominent ST elevation. You could see there that there is flow in the circ, and there's no flow in the LAD. So just before that picture, I wired both LAD and left circumflex. And then we took a picture. I was trying to resist not to inject. I didn't have time to use any imaging or IVUS to confirm whether I am in the true lumen or not. So wired both. You could see there spiral dissection in the left circumflex, no flow in the LAD, and the patient arrested. So CPR started. She had VF, and she had a DC shock. So I decided to stent. So stented the proximal to mid left circumflex 3038. This is the stent going. We just interrupted CPR for a few seconds. This is the second stent from the ostium of the circ to the proximal with another 3528. And then got the other stent into the LAD 3038 with CPR ongoing. At this point, she had almost 3 to 4 minutes of CPR. We already contacted the anesthesia team. This is the last picture I took, a very gentle puff. There is flow down both the LAD and the left circumflex. CPR still ongoing. The next question is which modality of mechanical circulatory support to use and in which order. So she achieved ROSC after a total of 12 minutes of CPR. We got some blood pressure, but she's on high doses of inotropes and vasopressors.
I just want to hear from the panelists, if you don't mind, Yani. And wallahi, you are lucky, akhi. How you get with the wire? Yani, this is, I don't know, any tricks to, I mean, if he has no IVUS, nothing, you know, how you got to the right lumen?
What about, if you allow me, we'll just we'll finish the presentation, then because it's going to be a lot of great discussion.
So we got the anesthesia team who had experience with ECMO in the COVID patients. They never put it in a cardiac patient. So they put the ECMO, I put the intra-aortic balloon pump immediately afterward. She was stabilized. We had a cardiac shock team in the chest diseases hospital. It's the only team available in the country. I contacted them very kindly. They took the patient straight away. Over the course of her admission, actually on the same night upon arrival to the chest disease hospital, she had severe bleeding with massive hematoma at the right femoral artery Ecmo insertion site. It was put in by the anesthetist, but the antegrade perfusion cannula was put in by the vascular surgeon because she was very obese lady and we couldn't even visualize it with ultrasound. So the cannula was oozing around it. The patient received a total of 12 units of packed RBC over 48 hours. She had acute pulmonary edema, recurrent SVTs. She had sepsis with blood culture positive. We are lucky. She is fortunate. She made a very good recovery. She was weaned from the ECMO day 6, balloon pump removed day 10. She was extubated on day 14 and discharged home after a total of 27 days length of stay in the hospital. She was fully mobile and independent. However, she got readmitted 2 weeks later from discharge with a right lower limb DVT and pulmonary embolism. She's still fairly well on therapy. She stopped her physiotherapy immediately after discharge from hospital. So just a quick slide about spontaneous coronary artery dissection. 90% of patients are women who present between the ages of 47 and 53 years old. They typically have a lower cardiovascular risk factors, less than 1% of all the acute MIs. Invasive interventions are usually advocated only if there is ongoing symptoms and evidence of ischemia. Beta blockers may prevent recurrence of SCAD because the recurrence is almost up to 18%. Statins not indicated. Blood pressure control is mandatory. Assessment of extracoronary vascular abnormalities should be considered. I just put this slide. I think it's very important. You don't need to memorize it. You just need to be aware of it. This patient came to the cath lab at stage A. She had acute STEMI with the diagnosis of SCAD. We were trying to help her by taking her to the cath lab, but all she got was we shifted her from a stage A to stage E, basically within 3 minutes, with the iatrogenic dissection of the coronaries by the guide catheter. So the take-home messages, if you have a shocked patient and you think that shock is due to an occluded artery, open the culprit lesion, please. Careful identification of the shock stages is very important. Also recognizing complications and being familiar with the available modalities of mechanical circulatory support is key to the management of these stages. Early recognition of the shock stage is very important. Use it early, remove it early as well is also important. You get the maximum benefit and the least incidence of complications. Indications for ECMO, in my simple mind, in acute STEMI patient is either incessant arrhythmias or cardiogenic shock stage D or E. I cannot overemphasize the importance of cardiac shock teams. There has been evidence that it does improve mortality. I think it's mainly derived from the aggressive monitoring and also the support. Swan-Ganz is probably a must in every patient, monitoring the lactate levels and multi-system failure. This is a point also reiterated in the previous slide. Large bore access is very important in helping reducing the vascular complications because our patient has got a few of them. Thank you very much.
Thank you very much. Great presentation and great slides at the end. We'll just allow our dear panelists to maybe.
Thank you, Mohammed. Very great presentation, and I think one way to answer Umar how you know in true lumen from false in the SCAD is when you put the wire goes inside branches. If you don't have imaging, this is one way of helpful.
Yep.
When you oscillate the wire and it goes inside branches, that you are in the true lumen. Otherwise, imaging is very good. If you lose the 3 layers in IVUS, means that you are in the false lumen. And here, Ecmo saved her life. And one thing I learned, Dr. Mohammed, that you are right, Ali, in young patient where you suspect a SCAD, I think, and re-estivation, I think femoral access is better than the radial axis, and then do diagnostic to see what's going on, rather than the traumatic. The XP catheter is sometimes very traumatic, going in deep intubation, and this is trigger the dissection.
So it's a very difficult situation. Congratulations on a marvelous outcome. She survived at the end.
Yeah.
There is an increasing interest in using cutting balloons in situations like these, particularly if you end up in the false lumen. Yes, you wire it, you try and get into a side branch, but then sometimes you're lost, you don't know where you are. Then there have been a few case series of using cutting balloons to fenestrate the dissection flap and create channels between the true and the false lumen to establish flow into the epicardial vessel. That could be one way of trying to restore some flow and, prevent progression of hemodynamic and electrical instability.
Yeah, thank you for the great case, actually, it really is. I think approaching those cases in suspected spontaneous dissection, just try to be gentle. I'm not sure I agree, go to the femoral artery. I would still go with the radial artery. However, I would go with the benign, what we call guide catheter, as opposed to XP catheters, very aggressive ones. Now, in terms of wiring those lesions, it's never easy. But however, usually what we've learned is to take the simplest, most dull wire in the world, try to cross that. Sometimes crossing it with a knuckle, so just bend it and just across, try to get through, but most often goes through the true lumen, depends on the dissection direction. I think using the intravascular imaging or microcatheters in those kind of cases might be so useful. Before you get to the distal vessel, make sure you're true. Either you can inject in the tip of the microcatheter, or use the intravascular imaging down the vessel before you cross to the distal end, because you may spontaneously take the dissection all the way down. That's one way of doing it, and then you can recommunicate if you are subintimal space into the true lumen, as my colleague mentioned. So I think just being gentle with those cases and have the expertise to deal with those occasionally might be treated as a CTO sometimes to communicate between the two lumens.
Okay, so just a quick comment regarding radial femoral axis. I think I probably disagree with you, Dr. Ali. In radial, if you are experienced in radial and you do more than 95% of your cases radial, probably your guide ambulation would be better with the radial. In STEMIs, there is mortality benefit with radial axis. In terms of taking a guide or a diagnostic, I think in SCAD, probably if you use a smaller French catheters, you will probably propagate the dissection. Well, you're more likely to propagate the dissection than the larger catheters. The other thing, taking a guide straight away is probably save this patient. If I had a diagnostic, I would probably have lost it. Lost the case completely. I wouldn't have time to put a guide and then rewire during CPR. And also going back to your point about putting a knuckle on the wire, my impression, I don't know what you guys think, probably putting a knuckle in a SCAD patient is not the best idea, because you could probably keep propagating if you are in a false lumen with the knuckle, it's probably you're going to end up worse. Especially if you're not sure. In my case, the main thing, I think a big advantage, I have 2 or 3 pictures with patent branches, so I could actually compare if my wire was going into branches or not. This is probably the main thing that I used in this case.
No, absolutely, I agree. However, the knuckle has an advantage over using the tip of the wire.
Yes.
So you're safer. As you know, you can be just, whether you're going to end up in the false lumen or you're going to be in the true lumen, it's either way. As I said, I wouldn't advance the wire too far. Yes. I mean, the feedback from the wire always very, very useful. Absolutely. And the more experienced as you are, absolutely, I know you will get the feedback from the wire. It will tell you immediately whether you are in a false or a true lumen. The knuckle will fly in no time into the true lumen, and you could feel the wire back feedback. So I think using your expertise in those kind of cases is the key, and just being gentle, I think, in every approach, the guide, the wire, every approach in it.
Great. Dr. Qadru, then Dr. Ali. Go ahead.
First of all, I have some answer to Dr. Abdullah. She have a question where just bring me back to the early 90s when we used 8 and 9 French guiding caster, and it was so hard, and we used sometimes create dissection just during engagement. And if you see any staining in the vessel, just direct the wire aware of the staining, and that's most likely in the true lumen. The other one is to go with the wire with the support of over the wire balloon, and advance the over the wire all the way to the distal, take the wire and inject through that lumen, and you see that. Now, my question, you put 2 stents in the circumflex.
Yes.
And we are talking about SCAD. I think just stenting for the proximal part, just to see the dissection, will be more than enough, rather than doing this whole metal jacket.
Yeah, but you could see the flap going all the way to the mid-circ, because in that picture you could see the flap going down. So probably you want to secure it, okay, top and bottom.
But usually in the SCAD, I prefer just to
put a proximal stent.
Just proximal stent to
Sure.
seal that. And I have 2 cases that I see just the proximal, and it went easy. So that's what I prefer. Now, what I missed, that you put stent in the LAD like blindly. We don't know whether that was true lumen or false lumen. And do you think that we were lucky that we...
No, I could compare it to the previous 2 pictures. I could tell that the wire is going into branches. But there's no way for me to definitely confirm. I was trying not to inject or resisting not to take more injections. And I didn't have time to put an IVUS or any form of imaging to confirm it.
Okay. And do we have any follow-up on this case? What happened to the distal LAD?
I didn't take her back to the lab.
Yes. Okay.
Okay. Dr. Ali?
I have 2 cases that I was able to take her to the cath lab.
Any time frame would you suggest?
Sorry?
Any time frame? Would you take her back in 2 weeks or a month or 3 months? Because they have a high recurrence rate.
I'll tell you my experience with those 2 cases, that the patient, both of them were women, yeah, and they were feeling well. And neither the woman nor her husband accepted to pay for that. So the best way that I was able to offer them, I'll do the cath and pay for that cath.
And that I was able to collect those follow-up on those 2 cases.
How about doing a CT coronary angiogram?
Well, that's is not accepted.
You are lucky that nothing happened to the patient. Otherwise, the patient will be in a problem, and you already paid for that.
Just regarding the radial femoral debate, I agree with you. Radial, yeah, it's been shown that it's STEMIs, it's better, less bleeding risk, and all of this. And we're all like, I think most of us here can say that we are experienced enough with radials. We know how to manipulate the catheters, but there's no question. Like when you are on femoral, when you do the femoral approach, you have more control of the guide catheter. You have more control of the catheters. You can be more gentle. So that's why it is preferred to go femoral. Even like the experts in SCAD, this is the recommendation. Sure. The other thing is that whenever you inject, you're right, it's a good thing you didn't inject very hard, but also don't use the auto-injector. Use manual injection with Absolutely. A manifold or something, and you have more control of the pressure.
Yes.
That's another...
That's very important. Thank you. Thank you.
Great. Thank you very much. Okay. Great case. Thanks a lot for what you did to the patient and our presentation. So we'll move to the last presentation by Dr. Hatem Al-Wadi.
Okay, assalamu alaikum. Good afternoon, everyone. I'm going to use this case to discuss a few issues that I think are still unresolved about the use of intra-aortic balloon counterpulsation in cardiogenic shock. And I think my task has gotten 10 times harder after Professor Spalding's session, but I'll try my best. I have no relevant disclosures, but I have to forward a disclaimer that I'm probably going to generate questions, and let me tell you from now, I have no answers. Looking forward to the discussion at the end. The case that I'm presenting is that of a 46-year-old man who had the usual cohort of risk factors: hypertensive, diabetic, dyslipidemic. He had a stent to his LAD some 5 years previously for an acute coronary syndrome. And like is the case where we practice, the man a year ago was feeling great and decided he was going to stop all his medications. He presented to us with a 3-day history of precordial chest pain, typical ischemic in description, and on the day of his presentation, the pain had gotten a lot more intense, radiating down his arm. He was nauseated, he was vomiting, and did something unwise. He actually drove himself down to the hospital. Walking into the triage area, he actually fainted. Rushed to the resuscitation bay, he came to. He was found to be diaphoretic, cold and clammy. He was hypotensive. He had prominent jugular venous distension, crackles in his lungs, and a loud S3. This was the ECG done immediately when he recovered his consciousness. Exactly 2 minutes later, he gets chest pain, and there's clear evolution of ECG changes. A quick bedside ultrasound showed severely impaired LV systolic function with an akinetic anterior wall, lateral wall, septum, and severely akinetic distal, inferolateral, and inferior walls. I hope it's projecting well. So with the clinical electrocardiographic and echocardiographic data we had, we decided to take him to the cath lab. And as you can see, he has a codominant right coronary artery that's occluded. He has a left system which is occluded. The stent is occluded in the mid-segment. The stent was in the proximal LAD. His aortic pressure at the time was 90 by 50 millimeters of mercury or thereabouts. His left ventricular end diastolic pressure was 47. I'll probably pause here and just poll the audience, just by the show of hands. Who would proceed without any support? Okay, we have 2 gentlemen here in the audience. If you had an intra-aortic balloon pump in your cath lab,
if you are good at using hemodynamic support, but if you're not been using it and have it on shelf, I will intervene without using the hemodynamic. So it depends, how experienced I am with that, because these will cause problems as well.
Right. That's a very good point. If you have a balloon pump in your cath lab, would you use it? Okay, so we have a few here showing their hands up. Now, if you had an Impella and a balloon pump, would you still use a balloon pump? No. Would you use an Impella? Right. Who would put this patient on Ecmo and perhaps send him for surgery? He's diabetic, he has triple vessel occlusion. So again, a few hands up. So what does that tell us? With all the data and all the discussions and all the sessions, there's no clear consensus. And this is important because you have to individualize your approach to the patient and the situation. Now, I had only a balloon pump available to me at the time, so I went ahead and I inserted it. And one thing I typically do is I cross back into the LV and check what happened to the LV EDP. And with 1-to-1 counter pulsation, his EDP dropped from 47 to 28. We're all intimately familiar by now with the AIBP Shock 2 trial, right? This was a multi-center randomized German study that enrolled 600 patients with cardiogenic shock in the context of MI with and without ST segment elevation and who were planned for early revasc. The primary endpoint was 30-day all-cause mortality in addition to a number of pre-specified secondary endpoints and safety endpoints. The study was negative because there was no between-group difference in the primary endpoint at 30 days. There was no difference in the primary endpoint in any of the pre-specified subgroups. There was no difference in any of the pre-specified secondary endpoints, and there's no difference in safety endpoints. 10 years later, from the time the study was published, when the lead author tweets about trashing the balloon pump and banishing it to garbage, he generates a lot of opposing responses in the medical community. Some completely disagree that we probably didn't study the entire hemodynamic profile of balloon pump counter pulsation. Some argue that we should probably be using it early. And some even responded saying, well, maybe you should put your Impella and Ecmo right next to it because based on the evidence we have to date, we really don't have definitive evidence for the use of these devices in shock, so why are we using them? So where is the problem? Is timing the problem? The BSIS-1 randomized control study used balloon pumps for a different indication, for high-risk PCI, and there they showed that early implantation of balloon pumps might have altered the outcomes favorably in patients undergoing high-risk PCI. At 6 months, there were numerically fewer mortalities in the pre-PCI balloon pump arm, and the difference became statistically significant with longer-term follow-up. So at almost 4 years, the difference between the two groups was statistically significant. Is that the same case with shock complicating AMI? Well, there's retrospective evidence showing that if you insert a balloon pump pre-PCI in AMI complicated by shock, there is a significant reduction in in-hospital deaths and major adverse cardiovascular and cerebrovascular events. There is a more recent cohort study, albeit a smaller number, but still, it showed a near 50% reduction in mortality and major adverse cardiovascular and cerebrovascular events in patients receiving the balloon pump pre-PCI, and more recently in about 200 patients, all comers with shock, be it from an ACS or without an ACS, early insertion of balloon pump was associated with a significant reduction in 30-day mortality. All of these studies unanimously showed that early insertion of balloon pump was an independent predictor of early survival in hospital or 30 days. The AIBP Shock 2 investigators went back to their data and published their article just last year, and their conclusion from their analysis was that the timing of intra-aortic balloon pump implantation pre or post PCI had no impact on outcomes in patients with AMI complicated by shock, and I would personally take that with a pinch of salt. For one, this was a non-pre-specified sub-analysis from the original study that came 10 years later in a study protocol that did not mandate support timing. The sub-analysis only included 275 patients of the originally enrolled 600 because data on timing of insertion was only available in 45% of the patients, and the overwhelming majority had the device inserted after PCI. I find that conclusion very hard to generalize when you have such limitations. Is the problem with the safety profile and the type of patients you're inserting this device into? The same group of investigators, comparing their Impella experience with a matched pair of patients receiving balloon pumps, showed that using Impella in patients with shock complicating AMI did not improve outcomes. There was no reduction in mortality, but there was a hefty price tag to pay with increased risk of vascular, bleeding complications, and sepsis. And this was confirmed in the randomized one-to-one comparison between Impella and balloon pump in AMI patients with shock, the IMPRESS trial. There was no difference in mortality at 30 days. There was no difference in mortality at 6 months, and a hefty risk of vascular and bleeding complications. And I think we all agree that shock is a continuum. So maybe the next time we consider using our mechanical circulatory support devices, we tailor it to the stage of shock. Maybe early shock does not require an Impella, because I think we all agree that these particular group of tenuous patients don't really tolerate any additional complications, be it vascular, bleeding, or septic complications. So maybe a balloon pump in early stages of shock is all you need, and maybe reserve your Impella and your Ecmo for advanced cases of shock. So with balloon pump support, we went ahead and we ballooned the infarct-related artery, restoring flow to the LAD, revealing a large diagonal branch, which we decided that we were going to intervene on. We dilated it, improved the flow, but created a dissection. And I wasn't 100% sure whether the circumflex was chronic or acute, so I decided to probe it with a wire and managed to get across with a Progress 40. And I was trying to get the balloon across, and we were told, the lab called us and said, you know what, his creatinine is 150, eGFR of 30, and that's when we decided, you know what, let's just focus our attention on the infarct-related artery. So we stented the LAD with a drug-eluting stent that was 3.5 millimeters wide, 28 millimeters long. POT was performed, and a 275 by 23 stent was delivered to the diagonal branch, and this was the final result. There was some distal embolization into the LAD. The patient will be coming back for interrogation of the distal left main and further decision on the circumflex after some viability assessment. His biochemistry continued to improve, or at least largely so. His lactate was 4.7 at presentation, down to 2.8 immediately post-PCI, and normalized the following day. His creatinine took a hit as expected, but came close to baseline at the time of discharge. The patient stayed with us for 5 days and then left in a stable condition. So the take-home messages, the points that I want to raise for discussion here, are the following. There is no doubt that we have an upward or an increasing trend in the use of mechanical circulatory support devices in patients with acute MI complicated by cardiogenic shock. Maybe we should be really thinking about the timing when considering your mechanical circulatory support devices, and maybe consider the stage of shock and tailor the choice of device to the stage of shock to the patient that you're considering it into. Thank you.
Thank you very much. It's a great presentation as usual, Hatem. And I think it's looking at the hemodynamic. From the beginning, you have diastolic pressure of 50 and LV-ADB was 47. So the gradient is almost nothing, like 3. And we know the coronary flow is in diastole. So that means no matter what you do without unloading the LV, you will not have a good outcome at all. So I think in these cases, if the LV-ADB is very high, putting in circulatory support up front before PCI is the way to go. Great. Dr. Abdullah, then we'll go to the panelists.
I just want to say what you already concluded at the beginning. You said, you know, we don't know. So we know revascularization, cardiogenic shock has been proven to help. Then since then, been planned to. All the hemodynamics, depends on who does the randomized clinical trial, give you a different answer. So we don't know. That's why I said, do what you're good at. But if I'm not using suppose I have a patient going to cardiogenic shock and I revascularize, then patient deteriorated, okay? Because that's what I know. If I do that I get the benefit. If I miss to use the, hemodynamic support and patient died, will I be blamed for that because there's no clear hemodynamic indication in cardiogenic shock at the moment? I don't know.
That's a very important question. What do the panelists think? I mean, just to add an extra level of complexity here, after all these years of revascularization, and I think Professor Spalding made it very clear that your first and foremost priority is to open the infarct-related artery. But we have been doing this since the age of dawn. Why is the mortality in cardiogenic shock still high? Then there is the concept of unloading the LV. Maybe we're just too focused on restoring epicardial flow, but we forgot that there are other parameters that we should be targeting. So maybe systematically unloading the LV, whatever modality you want to use, maybe that's what we need to be focusing on to reduce mortality from here onwards, in addition to restoring flow to the epicardial vessel.
If you see at the end of your procedure, the flow in the LED and diagonal start to get less, and almost like Timmy 2 flow at the end. And I think that's purely related to increase the LVDP again. And balloon pump is not enough. Maybe you need Lasix and need a lot of things that you treat him later on. So I think it's the hemodynamic definitely will play a big role in deciding which way to go first, either circular support or opening the artery. Personally, I think in your case, if you start with opening the artery, he will arrest before you save him.
Right. But what are you targeting with the hemodynamic support? That's the question that's still not clear in my mind. Are you targeting systemic perfusion? Are we targeting augmentation of coronary flow? Or are we targeting LV unloading? Because that, I think, in my mind, that's what will determine your outcome, or your patient's outcome, rather.
True.
And I think one thing comment is, first of all, it's a very good presentation and the good case that in such cases, I think the mechanical support did a great job. Without it, the patient will deteriorate, given that you did an echo, which showed severe LV dysfunction and nothing moving in. And almost he has looks like a left main equivalent where all the proximal are occluded. So sometimes when we face these cases in the cath lab, one way to do, of course, is to put mechanical support, but the easier one to do that is to put the balloon pump. It's not a time consuming. So we put the balloon, we do the case. If there is no improvement in the course of few hours, then and this is what we do sometimes, we turn it into other type modality of mechanical support, such as the impeller. So that's what we do, because balloon pump is very fast to do it. Then you do hit and run, and if no improvement, turn it to other modality of mechanical support.
Dr. Abdullah, then we'll go to Dr. Albert.
Dr. Hatem, thank you for a very elegant presentation. I really enjoyed it. I mean, I just want to agree with you on the early, if you're going to use mechanical support, you're going to insert it early, and you need to match the degree of support to the degree of the shock the patient in. Just a comment about the point you raised with regards to why are we still opening the arteries and the patients are still having such a high mortality with cardiogenic shock. And I think the reason is the cardiogenic shock, it's not only ischemia, it's ischemia, increased LVEDP, and low MAP. Yeah. And opening the artery only deals with one of the triangle of this. But when you added the balloon pump, you improved the mean arterial pressure and you reduced the LVEDP, which is also important in coronary perfusion. Because as you know, coronary perfusion depends on perfusing pressure as well as LV wall stress or LVEDP. So I think that's a very important concept, that why mechanical support can be really helpful. And that's why I think putting it early makes more sense than waiting, because it can give you effect very quickly. And putting a balloon pump doesn't take a really long time. But doing the PCI, you have no idea how long it's going to take, or how complicated it might be. The last point I'll make about the common concept that people saying there is no data for mechanical support. There is no data. There is no data, but that doesn't mean it doesn't work. The fact that we don't have the data doesn't equal that it doesn't work. It means that these are cohort of patients that are very difficult to study. And I think the shock trial gave us more questions than answers. And I think that's another issue. A poorly designed trial can be worse than no trial. Okay, thank you.
Albert?
Yeah, no, absolutely. I think that's one thing to say about PCI, the culprit vessel. The mortality was before PCI was 90% in those cardiogenic shock. Now it's down to 50%. So we have improved significantly by opening up the artery. Let's not deny this. Yet they are very high risk. Still mortality 6 months down the line, a year down the line is still very high in those, regardless whatever we do. The support, I think, as you've mentioned, which concept, which part of it is the most crucial part. I don't think we've defined this yet, but I think we all agree perhaps the LVEDP, the stress, the wall stress, all these factors are the key in those patients. I think there is more to study. The number of trials being done on cardiogenic shock, as you know, they are very few because it's very hard to recruit into those trials. And the number of trials being stopped because they couldn't recruit anymore is far more than the one that have been accomplished, as we all know. I mean, there's only 3 or 4 trials across the board. I think designing proper trial, make it multi-center in a very high volume experience center is essential. I think, for example, using the impeller in very experienced center, it doesn't take long. Basically, they can do ultrasound guided auxiliary access. I've seen it done live in TCT. Within 10 minutes time, they've put the impeller down. So I think the key part is learning, and the experience in centers makes a huge difference in terms of support. The balloon pump is the easy option. Usually we used to say in the UK, by the time you registrar, put the balloon pump in, you've already opened up the vessel. So it's something that I think the concept is very complicated, isn't it?
True, very true.
Great. Yeah. Final comment from your side. Any comment from your side?
No, that was all I was hoping for, to generate more questions than give any answers, and I think I succeeded, so thank you.
You did. Great job. Thank you very much for presentations. And thank you very much for our dear panelists, and it's a great session, a lot of discussion, and we'll move to our last session of the day. For Abdullah Shahab.